Alright, in this video I want to talk about preeclampsia and a lot of the physiological signs and effects with preeclampsia, maybe what to look for as a healthcare professional, as a nurse, as a doctor, so on and so forth. So we kind of know probably, the three major things to look for in preeclampsia, and that's increased blood pressure, edema, and a positive protein test in the urine. So we know that those are kind of our main signs, but if you're really going to get a firm understanding of this disease process and really give it the respect that it kind of deserves for the severity and fatality that it can really cost your patients, in my opinion, I really think that you need to have kind of a more intuitive understanding on where these things come from as a whole and how the disease works. And if you typically ask, or at least the people I've spoken with, kind of what preeclampsia is, you almost always hear, well, it's hypertension and pregnancy, or it's high blood pressure and pregnancy. And maybe they know, pardon me, maybe they know that it eventually leads to seizures, and that preeclampsia is bad. Oh, is it bad? It's really, really bad. Well, if you're really going to treat this disease and treat someone that has this, you have to think fast and think on your feet. And in order to do that, I think that having an intuitive knowledge on how this disease works is really going to help you out. There's no worse or traumatizing feeling than to watch somebody who's dying right in front of you and not knowing what you can do to help them. So preparation starts here and now. Let's talk about preeclampsia. Well, to understand preeclampsia, you kind of have to know a little bit about pregnancy, and you probably do know a little bit about pregnancy at this point. We've got a pregnant mom here on the right, and she's got baby inside her, and here's the placenta. Well, in a normal pregnancy, you have these spiral uterine arteries that will attach into the myometrium of the placenta and provide perfusion to the baby. This little guy over here is the developing baby. And you can kind of see on the right here how these spiral arteries will invade all the way in to the placenta, which is what we want. We want these to have a really good deep connection into the placenta so that we can have as much perfusion as possible. Perfusion is a good thing in this case. So we want as much perfusion as possible with this. This blue stuff in here, this is the placenta in here. We want this to perfuse all the way in there. That's a normal pregnancy. So let's take a quick look at an abnormal pregnancy right here. All right, so this is kind of a comparison of what these guys, let me scroll down a little bit. This is a non-pregnant uterus and spiral arteries in a non-pregnant woman right here. And you can kind of see, they go all the way through, but they're not really perfusing as well as we would want in, say, a normal pregnancy over here. And you can really see how this opens up more, and we get a lot more blood flow in there. Which, again, this is good. This is what we want. Well, this is what a preeclamptic patient looks like. And this happens from it begins to happen from almost the very beginning of pregnancy in preeclamptic patients. And we don't really know why they don't get all the perfusion that they need. We know that only about half of these spiral arteries, that's these guys right here, and this whole thing right here is a spiral artery. We know only about half of these will attach and invade all the way in to the placenta and the myometrium like we want them to. And the other half end up looking kind of like this, where they're not really getting all the blood flow that they would get in a normal pregnancy. So what happens whenever that takes place? Well, whenever you see that, that triggers a response to your brain here, and it says we have hypoperfusion in our body. Oh, that was horrible. Sorry, I have really bad penmanship on this thing sometimes. Hypoperfusion. and our body. And it's kind of the same response that your body would get if you were bleeding out. Bleeding out. So let's say you've got a little guy right here, and I am not an art major, so you're going to have to forgive me. And let's say that his leg has been cut off, right? And he's bleeding out right there, and he's losing a lot of blood. That's going to trigger in your body from your brain a vascular response. And what it's going to do is it's going to shunt blood away from this wound and redirect it to this guy's brain, heart, and lungs, because those are the vital areas that he needs to keep him or her alive. Well, it's no different whenever you get this hypoperfusion like you do right here in the placenta. It's no different than if you had a major wound on your leg or if your leg was cut off. It's the same thing as far as your body's interpretation of it. So what begins to happen, let me draw a picture of a vein or an artery here. I'll draw a picture of an artery. What begins to happen is, and let me make that just a little bit better. There we go. Is in a normal pregnancy, you have a balance of vasoconstrictor hormones and vasodilator hormones. And this is important. This is kind of what you want in a normal pregnancy whenever you don't have this triggered response that, maybe you're losing blood. Well, in a hyperperfused pregnancy or in a preeclamptic pregnancy where the body thinks that it's losing blood and it's hyperperfused, you have an imbalance of these hormones. So you have more vasoconstrictor hormones than you do the vasodilator hormones. So the body thinks, hey, I'm losing blood. I need to redirect it away from my uterus, away from the uterus, and redirect it to my heart, my lungs, my brain, this guy up here. The body doesn't consider a baby or the placenta or the uterus a vital organ. It considers your heart, lungs, brain as vital organs. So it will redirect blood away from the uterus. So it does that by constricting on these veins and these arteries. So it'll constrict, relax, dilate. Constrict, relax, dilate. And it'll do this over and over and over again, which will lead to one of our very first signs of preeclampsia. And you can probably guess it. It's increased blood pressure, right? You have vasoconstriction, same amount of volume in blood, which equals basically increased pressure. No different than any other type of system, same way in your circulatory system. So you have this blood flowing through, and there's constant constriction over and over again on these vessels. Eventually, over time, that's going to wear them out. So these vessels get worked and worked and worked. This vasoconstriction is all right whenever you have a wound or a cut, but your body hasn't really ever been built to sustain a hyperperfused state for a long, long period of time, like what you would experience in a 9-month pregnancy. So our veins and arteries aren't really built for that, so they get worn out and they get these little micro holes inside our arteries and our veins. Well, whenever we get these little micro holes inside our arteries, fluid begins to pour out. So we'll have fluid come out here, out this hole, maybe out this hole, out this hole, and out that hole. Well, whenever that happens, it triggers a response in our body where the walls of our vessels will release a lipoprotein called fibronectin. Fibronectin, and I think I'm spelling that correctly. And it's not really important that you know necessarily what fibronectin is or that it is fibronectin, I would say that it's probably important that you know that it is a lipoprotein, or mostly just that it's a protein. Because let's say that this protein, we'll make it a green color like this. Let's say that this is released, and ideally what it's meant for is to plug holes, these little micro holes that are in here. They're supposed to come in and plug these little guys so we don't keep losing fluid in our bodies like we are. Well, that's all fine and dandy, but because of the immense amount of stress that's being put on a preeclamptic woman's arteries, these guys can't plug all the holes. So they're just stretched too thin, and they end up leaving the veins and arteries and going out into the intravascular spaces or the interstitial spaces. So you have these guys floating around out here now. Well, what do we know about protein? Protein and water, or H2O. We know that protein, or that water likes to follow protein. So whenever this happens, we get the vascular response, fibronectin's released, it goes through these little micro holes because of all the constriction on the veins. Fluid, then water, follows this protein, and that leads us to our next response, which is edema. So you can see how this hypoperfused state is starting to trickle down and make all these effects that is preeclampsia. So we've talked about our first sign and symptom here being the increased blood pressure. That's where our edema comes from, is this lipoprotein called fibronectin getting released into the interstitial spaces, water following it, causing the edema. So what's our third sign? Well, we know that the third sign is the protein in the urine, right? And we know that protein, this lipoprotein, is being leaked out into our interstitial spaces. Well, how does that get, in turn, into our kidneys? Well, if you think about it, our kidneys are one of the most vascular organs in our entire body. And I'm drawing renal pyramids here. And you can kind of imagine how, and actually I've got a picture of it right down here. Let me draw this kidney down here again. You can kind of imagine, you know, this is the afferent artery and all that, and you can see them right down here in this. These arteries and these vessels, they're leaking fluid and lipoproteins out of these as well. So all this protein is coming out of here. Well, that translates into the loop of Henle, which you can see right in here. So the protein releases out of the arteries and veins in the kidney, gets into the loop of Henle, goes into the ureters, goes into the bladder, gets into your urine stream, and then you test positive for proteinuria. So that's our third sign right there. And you can kind of see how this cascade trickles down into the positive protein. I can tell you that we measure the severity and the progression of preeclampsia by the amount of this protein in the urine and by renal function. The more protein and the worse the kidneys start to lose function on, the more the disease is progressing. And that's a really, really bad thing. But we'll talk more about that in the next video on HELLP syndrome. But more importantly, what's another question that we ask preeclamptic patients? You may have heard this with right upper quadrant pain as well. Have you had any epigastric pain? And it's in your right upper quadrant if you think back to anatomy. So where does this come from? Well, again, as you can probably guess and maybe tell a little bit from this picture, the kidney or the liver is a very vascular organ as well. And if you see all these little arteries and veins floating around in here, these are no different than the kidney and the rest of your body. They're squeeze, release, squeeze, release, squeeze, release over and over again with the vasoconstriction. Well, whenever that happens, and the proteins leap out of there, it causes the epigastric pain, and that in turn causes a clotting cascade inside the body as well. So what do I mean by that? Let me draw another artery here. Got an artery. All the squeeze and release is happening on this. The body and the brain thinks I'm leaking out. So what's it going to do? It wants to plug the holes and wants to cause a clot. So it begins the clotting cascade. Well, what that means with epigastric pain and your liver, let me do a different color on this, on here, is you'll release these through the process of a common pathway and fiber and fibrinogen, the whole 9 yards with that. And I won't get deep into the clotting cascade, but you can probably remember and imagine from maybe other classes. But these clots will start to form, and the more that they start to form, and the liver especially, it makes it harder and harder for blood to flow through, because it's got to work around all these clots and all these clotting factors to get through. Well, that creates a hypoxic state. And then in some of these, maybe in the more distal portions of the liver, these clots will actually get so bad that it will cut off blood flow completely to parts of the liver. And whenever that happens, you'll develop ischemia. And ischemia is just a $1 million word for it's losing blood flow to a part of the tissue. That's really all it means. And if you've had any semester of nursing school, then you've probably had it beat into your head, that pressure ulcers are bad. And pressure ulcers are just ischemic points of the body where they're not getting enough blood flow to them. It's no different in the liver. Well, fortunately, whenever this happens with a preeclamptic patient, really the only cure is to birth, to get the baby out, to stop this whole, and get the placenta out, to stop this whole neurological and chemical reaction that's going on within the body. But the good news, at least with this portion of preeclampsia, is that for mom, there's almost never any long-term side effects with this. The liver is able to heal itself and it regenerates, and we really don't have to worry about a whole lot of long-term side effects with mom. But because of this ischemia and this hypoxic state, that's what causes the epigastric pain inside mom. Now, if every surgeon were to go in on every preeclamptic patient and go in further and look at the actual liver after delivery, they would find these little ischemic points all throughout the liver here. And it's those and the squeeze release that leads to this epigastric pain. So what else do we ask preeclamptic patients though? Have you had any? Do you have any? We ask about headaches, right? Do you have a headache? That's a big one. What about blurred vision? Blurred vision. That's another one we ask about. Well, you can kind of think through these same rationales with everything else. The head is very vascular. The eye is very vascular. Kind of the same things happen with those. And of course, that's probably a gross oversimplification, but I'm not going to get too deep into it unless, interest arises, and maybe we can do a video about that. But kind of the same thing happens with those. The important thing to think about and take away, and mainly why I emphasize so much on the liver, is the liver and the increased liver enzymes will eventually lead to another situation called HELP syndrome. And this is what my next video is going to be about. So I hope you've gotten kind of a basic understanding, at least about the physiological effects of preeclampsia, where it comes from, how it's important, and how you can translate, at least in some small part, this knowledge into your interventions and your care that you give to your patients now. If you like this video, stay tuned, because I'm coming out with the HELP syndrome video next, and it's going to be just as good, if not better. Thanks for watching.